Samruddhi madam, you can
Yes,
start.
ma'am. Yes, ma'am. A very good evening and a warm welcome to all the respected dignitaries, our esteemed speakers, and viewers from all across the state for this yet another episode, an exciting episode of Thursday Thrills, organized by Maha IIP and Maha IIP Women's Committee. Today's topic of discussion is advances in thalassemia. I am Dr. Samruddhi Vasnik. I will be your host for this evening. I am secretary from AOP Chandrapur. I am immensely grateful to Dr. Pakmude sir, Dr. Pawar sir, Dr. Jaya ma'am and Dr. Amog ma'am for giving me this wonderful opportunity to be your host for this evening. As you all know, that thalassemia is a hereditary hemoglobinopathy affecting millions of people all over the globe. And we celebrate World Thalassemia Day on 8th of May. And it is celebrated to raise awareness, promote research, and support individuals affected by this condition. It serves as a reminder to advocate better treatment options and accessible healthcare for individuals living with thalassemia. And the theme for 2025 is Together for Thalassemia, Uniting Communities, Prioritizing Patients. And for today's topic of discussion on advances in thalassemia, I take this privilege to welcome our wonderful esteemed speakers, Dr. Ratna Sharma ma'am, who is pediatric hemato-oncologist from Thane, and Dr. Amit Jain sir, who is pediatric hemato-oncologist from Mumbai. Welcome sir, welcome ma'am. Now, before these esteemed speakers transfuse their abundance of knowledge and we plunge into this webinar, I request our MAIP President, Dr. Sanjay Pakmude sir, for his welcome address.
Namaskar. Welcome to the Thursday Thrills, the program organized by Women's Wing of Maha IIP. First of all, let me welcome today's speakers, Dr. Ratna Sharma Madam from Thane and Amit Jain from the Mumbai, and our moderator Amit Saxena, Secretary Navi Mumbai as a moderator. And session conducted by Dr. Samruddhi and Dr. Amov, and Women Wing Chairperson Dr. Jaya Shivalkar Madam, our convener Dr. Sanjay Deshmukh, Dr. Amol Pawar in his absentia, and other members of MAHAIP, CIP who are joined today's program, as well as all the attendees who are attending today's program. As Samruddhi has already said, on the 8th of May, we have celebrated the World Thalassemia Day. On that day also, we have conducted one program, The Basics and Beyond of Thalassemia, where 3 topics were covered, where overall review of thalassemia, then even the little bit it was touched as a bone marrow, but not fully. So today we are again taking this program of advances in thalassemia, and we got 2 experts from Mumbai, and they are going to enlighten us on this particular topic of advances in thalassemia. As we know, stem cell bone marrow transplantation is the only cure for thalassemia. More than 1,000 transplants have been done worldwide. Transplantation is safest when hematopoietic stem cells are obtained from an HLA identical sibling without thalassemia, but only 25% of siblings will be identical. And transplantation is associated with a mortality rate of just 5%, a graft rejection rate of 5%, and occurrence of significant graft versus host disease of just 5%. So for the well-chelated children without liver disease, event-free survival rate after transplantation is 85 to 95%. So let us hear from our experts. They are going to highlight these advances in thalassemia, and it is going to enrich our knowledge. So over to you, Samruddhi.
Yes, sir. Thank you, sir, for your welcome address. Now, I would like to request MAIP Treasurer, Dr. Ravindra Sonavne, sir, for his opening remarks.
Hello. How was it?
Yes, sir.
Actually, I just reached Bangalore 1 minute back. Okay, so I first of all congratulate MAHAIP Women Committee under the banner of MAHAIP, President Dr. Sanjay Pakmude sir, then Secretary Dr. Amol Pawar. I congratulate Jaya Shivalkar madam, then Dr. Amuk Shahane, and Dr. Kashmiri Badbade, and Women Committee other members for conducting every third Thursday the Thursday Thrills. In I think March, they have conducted Down syndrome, which was attended by more than 150 delegates. Then Autism Awareness Day a month was celebrated by arranging a webinar. And now this World Thalassemia Day, which was celebrated on 8th May, the theme is to unite the communities and prioritize the patients. So together we can cure the thalassemia patient. Already Sanjay Pakmode sir elaborated about the thalassemia day's significance. So okay, thank you.
Thank
And
you, sir.
also, Dr. Amit Saxena, moderator for today's session, and speakers, Dr. Ratna Sharma and Dr. Amit Jain. And I also welcome MMC Observer and online delegates. Thank you.
Thank you, sir. Now I would like to request and welcome Dr. Sanjay Deshmukh, sir, our MAHA-IIP convener, for his opening remarks.
Good evening all. Welcome to the all esteemed MAHA-IIP office bearers, Women Committee office bearers, Central IIP office bearers. You know, last 1.5 months, we are celebrating hematology awareness on MAHA-IIP platform. It starts from 17th April as a World Hemophilia Day. Then 8th May, it's a World Thalassemia Day. And now next month, it will be the Sickle Cell Awareness Day. So this 1.5 to 2 months is our always priority to sensitize on these disorders. And you must be happy, Maharashtra government has started now specific day hematology care centers in each district of Maharashtra, so that all the patient will be taken care in diagnosis, management, and awareness at the district levels. And we MAHA-IIPs are always on front to update what is the new in the hematological disorders. And today we have two experts, Dr. Ratna Sharma ma'am and Dr. Amit Jain from Mumbai, which will be ably moderated by our dynamic Navi Mumbai Secretary, Dr. Amit Saxena. So my best wishes. And I also appeal all MAHA-IIP members to kindly register for MAHA-Pedicon, which is happening in Kolhapur in October. So we'll put the link in the group. It's our conference. So sincere request to all to register for the MAHA-IIP conference, MAHA-Pedicon. Thank you. Thank you very much.
Thank you, sir. A quick note for the viewers, kindly post all your questions in the chat box and which will be addressed at the end of the session. Now, I would like to request and invite and welcome Dr. Amit Saxena, sir, to moderate this session. He is a professor in pediatrics at Dr. D.Y. Patil Medical College, Nerur. He is in charge of pediatric hemato-oncology specialty at D.Y. Patil College. He is secretary IIP Navi Mumbai, and he has publications in national and international journals. Welcome, sir.
Yeah. Thank you, Samruddhi, for the introduction. And so thank you so much. And I would like to thank Dr. Deshmukh, Dr. Pakmode sir, Dr. Deshmukh sir, Dr. Sonani sir, and Dr. Shayab, Twelkar madam, and Amok to give me this opportunity to moderate this session, which is close to my heart on the Thalassemia Week, I would say. And what best speakers I can expect to have Dr. Ratna Sharma, will be my teacher and guide and mentor kind of. And Dr. Amit Jain, who has been also closely associated, quite a good friend now. So we all know, we have seen a vast difference in the management of thalassemia over a period of years. Like when we were residents, we used to have, somehow give them transfusion therapy and chelation therapy. But now we are moving towards cure. And definitely we aim towards preventing the, thalassemia altogether from, a single test like HB electrophoresis done antenatally. We are trying to go towards that, prevention more than cure. But there are still a large number of children who are still being born with thalassemia. But we have a cure. And the first topic that, can we have the slide for Madam, Ratna Madam, please? Our first speaker is Dr. Ratna Sharma. She is a very well-known face in the field of pediatric hematology and oncology. She has done her fellowship in pediatric hematology oncology from MEHS, in BMT from MEHS, and she also did a training in the PHO and BMT from Medical College of Wisconsin and in the United States. Currently, she's working in CTC, which is one of its kind center, a center run by BMC in Mumbai, which is providing thalassemia transplants for thalassemia children almost free of cost. She's also attached to Jupiter Hospital in Thane, and she has got multiple publications to her name. So over to Ratna Madam for the first topic, that is, what does the pediatrician should know about before the patient is sent for transplant, and after he completes his transplant, what care we are supposed to take. That is what we are going to learn from Madam. So over to you, Madam.
Thank you, Amit, and thanks for that kind introduction. And I would like to thank all the organizers here for giving us this opportunity to create awareness about thalassemia, the advances in treatment, and what we all can do together in future. So a big thank you to the Women's Committee of the Maharashtra IAP. I must congratulate you all for taking this initiative. Thank you very much. I'll begin my talk. I'll just share the slides so that we can have a smooth discussion. So I'm going to keep it very simple and focus on the role of pediatricians. My slides are visible, I suppose.
Yes, ma'am.
Yeah. So, greetings from my center at Borivali. Most of you all know the center and have been referring patients for comprehensive care and for the potential treatment option of transplant. So a big thank you to all of you over there. My talk will cover a few basics which you need to know to understand your role pre and post BMT. What you need to know that HSCT for those living with thalassemia that is available, how it can improve the quality of life of these people. What is the pre-transplant care that is expected, where you will be playing a major role? What are the post-transplant issues where again we would want you all to be involved? And how we can share the care that is required to improve the long-term outcomes. We will also be covering a few advances in the transplant field, how it is going to impact the future of those who cannot be transplanted today, whether we'll have options for them in future. So that is just a brief, topics through which I'll take you through in the next 20 minutes or so. So a very small discussion on the basics, what are stem cells, because now it's not a bone marrow transplant, the correct term is hematopoietic stem cell transplant. So stem cells are a population of undifferentiated cells which have the ability to divide for indefinite period. They can self-renew and they can generate a functional progeny of very highly specialized cells. So once we know that what we are doing is basically a stem cell transplant in the given scenario where the marrow is into ineffective erythropoiesis because of a genetic defect. The procedure is very simple in terms of understanding, but not so simple in terms of actually implementing it when it comes to patient care. The hematopoietic stem cells of any donor from any source, basically, which could be the marrow or the peripheral blood, are given to the recipient who is diseased with the intention of repopulating or replacing the original hematopoietic system. And if this can clear the disease or take care of the disease or give a cure, which may not happen in all genetic disorders, then that becomes a reason to do a transplant. So as we all know, the source of stem cells are bone marrow, the peripheral blood, and the umbilical cord. Both types of transplant, the bone marrow and the peripheral blood, are currently being implemented. Umbilical cord is being done in some centers, but because of various other challenges, I will not be covering it because we are not into umbilical cord stem cell transplants in our country in a major way. So if you want to understand what are the two types of transplants, one is autologous and one is allogenic. Autologous is when patient receives their own stem cells. So it is used for certain conditions where you can actually, you're not trying to eradicate the disease, but you're going to consolidate like in malignancies. However, autologous transplant will be a way for gene therapy in thalassemia in future. So you need to understand that these patients will be undergoing gene therapy, which will amount to autologous stem cell transplant in them. Where ex vivo, there will be corrections done and reinsertion of the stem cells to take care of the genetic defect. The second thing what we are doing is now currently what is being done is allogenic transplant. So as a pediatrician, you should know that what we are doing is allogenic transplant for diseases which are hemoglobinopathy. Here the patient receives stem cells from a related donor or an unrelated matched donor in a current scenario. So these donors could be a syngeneic donor like a twin who totally matches, which is like too lucky to have. But then in that case, you need to screen for the disease as well. It could be a sibling who's matched totally, or a father or mother who have matched. So we call them matched family donor. And in today's scenario, with the advances happening in haplo, we could also offer transplant with a haplo donor, which could be a father or a mother who's not matched totally, but at least has 5 out of 10 antigens which are matching. Then comes getting a donor from a registry. So these are unrelated donors who are willing to donate their stem cells for anyone across the globe, and they have enrolled their names in registries where you could actually write to the registries and give the HLA report of the patient and ask the registries to search for a match. So there will be a role of pediatricians in helping the patient to actually go for this search if there is no match in the family. So the indications, as a brief understanding of the indications of transplants. Now, there are multiple indications in pediatrics. Now, we all know with the advancements in the field of transplant for the last 10 years, referrals are being made by pediatricians. So we know that most of the pediatricians now understand where the bottom line of treatment, where it used to be mentioned, transplant is the cure. The referrals have started coming because more and more centers are doing transplant. And the families also understand now that this is an option available. So here we are going to talk of transplant only in hematologic condition, which is thalassemia, whereas there are other indications for which referrals are being done. Dr. Donald Thomas is considered as the father of transplant on this planet. He got a Nobel Prize for it in 1990. And if you look at the transplant that were done for thalassemia, the baby steps started long ago in 1981. But an interesting part is that in the same year, two people or two groups did transplant. The Seattle group did it to a 16-month-old child with a HLA identical sister, and the transplant was successful. Whereas in Italy, the Pizarro group did it in a 14-year-old multiply transfused child, HLA identical marrow, again from a sibling, the brother, but the transplant was unsuccessful. These two cases tell us what is the pediatrician's role in today's time to get a good outcome post-transplant. So what do these two cases tell us? That the younger the patient, the transplant is likely to be successful. Older the patient, multiply transfuse the patients, the chances that the transplant will be successful go down. But in today's time, we can improve these outcomes by various methods before the transplant. But these two cases actually told us how to go about, how to move in the field of transplant. So this was way back in 1981, and we have come a long way. From 1981, we have come to 2025. And what have we learned so far? We have learned that we need to get them transplanted at a young age. We need to preferably have a HLA matched donor. I'll just use the pointer so that I'm a little more specific. Yeah. So younger the age, better the outcomes. If there is a HLA matched donor, the outcomes are likely to be better. But in today's time, a haplo match, that is one of the parent could be a haplo match with newer techniques, with newer preparation techniques before the transplant, with good monitoring techniques, with good medications available to control GVH, we could be getting something very close to results which could be similar to a matched sibling or a matched family donor or even a matched unrelated donor transplant. If the patient doesn't have any organ dysfunction, we could give a better result. So here, in these areas of no organ dysfunction, where patients are being managed by the pediatricians, they could ensure that if the child is heading for a transplant, then they need to monitor the child accordingly so that we end up giving better outcome options to these patients when they finally reach with the intention of cure to a transplant center. So 20% of the patients will have a matched family donor. So their risk of something called as graft versus host disease is going to be minimum. The siblings of transplant who would match, even if they are thalassemia minor, they can be a donor for transplant. So this is a place where the pediatricians can counsel the family that a sibling who matches, even though he is a thalassemia minor, or one of the parent who matches fully, even if he's a thalassemia minor, he or she, he can still donate stem cells to the patient. So that is one thing where you can, counsel the family. The remaining 80% of the patients who don't have a donor in the family need an alternative donor. And by alternative, I mean someone from the registry, or a haplomatch transplant could be done in settings where the team is, has the expertise to do a haplo transplant. So talking about registries, the more people register in the registries, more the chances that a patient may find a donor in the registry. A lot of efforts are being made in India to create awareness for people to come forward and voluntarily enroll in bone marrow donor registries so that they could become potential donors for someone who needs stem cells in future, whether it is hemoglobinopathy or oncology case or any other condition where transplant is required. With new evolving strategies, as I told you, haplotransplants in future will be an option for thalassemia, and we are working towards better methods of haploidentical transplant. Though still in some centers, this expertise may not be available. There are centers who are trying to excel and bring the results equal to matched sibling and matched family donor transplant. So, why do we do transplant? Because that is the only curative option in patients with thalassemia. Autologous transplants in thalassemia will be an option when gene therapy comes in. We need to understand that why we want to do transplant in a patient who's otherwise going to be managed and living a life which may be challenging, but may have, if everything is available, may have a decent quality of life. So there are a lot of aspects which have been discussed, and these need to be told to the family also. The overall survival, the lifespan may be longer. The cost involved in managing any patient right from the time of diagnosis and onwards in conventional medical management is definitely going to be more as compared to doing a transplant. The risk involved with transplants are transplant-related mortality. It's not that it is totally a risk-free procedure. There is a risk of recurrence of the disease if the transplant fails, or landing up with aplasia if the patient does not have his own recovery of his own stem cells. So in those risks have to be explained, have to be taken. The family has to be ready to take that risk. Then transplant is something that we can go ahead with. And the quality of life, though we don't have direct studies to compare, but in a controlled setting where the transplant goes smoothly, there is no GVH, we can assure the family that the quality of life post-transplant is going to be better than what it is going to be with comprehensive care that is being offered in today's time with all the challenges that come with it. So these things have to be known to pediatrician when they are referring so that they can speak to the family about all the plus and the minus of transplant and of the conventional medical management. So anything that is red tick over here is meant for the pediatricians. The process of HSCT, it's a teamwork. We have to be all together in it, and the role of pediatrician would be in the preparatory phase as a team, and in the post-engraftment period when the patient is out from the hospital, out of the minute surveillance of the transplanting team, where it will be a joint effort of the pediatricians, the physicians, and the transplant team together to ensure that the outcomes in the long run are good. So in the preparatory phase, we have to determine whether a patient is eligible for transplant. And here, the pediatrician can do some basic work before the patient is referred to us. A genetic confirmation of diagnosis is always mandatory. If it is done by the pediatrician, the time taken to move ahead for transplant is obviously going to be less. The patient has to be having a good weight, so nutritional support prior to transplant. You need to be monitoring these patients from diagnosis till they are undergoing transplant, that they maintain good health, they are vaccinated, their iron overload is kept to minimum or zero by giving them good iron chelating drugs with adequate doses, confirming compliance, ensuring that they don't have organ dysfunction. Then these, when Dr. Sanjay just mentioned, if they are chelated well, if they are in optimum health, which totally depends on the treating pediatrician under whom they are, then these patients are likely to have good outcomes. So patients being referred after they have when they have significant iron overload or already have organ dysfunction, it becomes too challenging to take these patients up for transplant. We have to aggressively give them iron chelation. That may not be adequate even if we give them intravenous Desferal for a few weeks, because the iron overload is proportionate in the inversely proportionate to the outcome and the complications that can happen in transplant. So the performance status, the comorbidity index, all that matters to give them a good outcome, which is Dr. Sanjay mentioned, around 80 to 85% success rate we can quote if all this is taken care of, and this is totally in the hands of the pediatricians who are managing these children. In today's time, after the oral iron chelators were made available, which were, which could be dispersed in water, we have realized that the compliance to iron chelation has become better. So now we can expect referrals of children who are chelated well and are going to be fit for transplant and therefore see better and better outcomes. Screening for suitable donor by HLA typing can be also done by the pediatricians, because this is a simple test. It could be done by a buccal swab or blood samples, and it could be sent to labs which are doing HLA typing. There is a list of labs available in India who do HLA typing. And HLA typing can be done to understand whether this patient actually has a match, or his sample or his report needs to be sent to a donor registry to find a match for him. So this basic workup can be done at the level of pediatricians. So this is how the HLA report looks like, and they give the results at the end, whether there is a 10 by 10 match or not after going through all the antigens here. It is not too complicated, and you would know after you see the report whether this patient has a match in the family or not. So preparatory counseling is going to be a joint effort. Once the patient is referred to us, the patient will obviously go back to you as a pediatrician and have the same questions, certain doubts after what is spoken to him. Here you need to reinforce certain things which you have to be also thorough with, that what are the steps of the procedure, what are the probable complications that can happen, the early complications when the patient is in the unit, and the late complications like chronic GVH. What will be the quality of life after transplant? The duration of stay in the hospital, it's going to be like around minimum 6 weeks, starting from conditioning to actually stem cell infusion, then the engraftment period that takes about 14 days to 21 days, and the post-engraftment period. We expect the patients to stay in the vicinity of the hospital where the transplant is done for at least 6 months to 1 year, based on how the patient is doing. The patient is doing fine, sometimes we send them back to their hometown if we have a shared care understanding with the pediatrician, and the patient is followed up once a month thereafter. The outcomes as per literature, the risk of failure, the risk of aplasia, though it may be less in those who are well transfused, well chelated, it needs to be counseled and told to the family. They have to be psychologically prepared, because you have a child who's otherwise doing well on transfusion, on chelation. As a comprehensive care, he's getting the optimum, treatment. And still, we are taking a patient for a major procedure like transplant, where complications are known, where TRM, that is transplant-related mortality, risk is always there. The risk of failure, the risk of aplasia, the need for second transplant in rare cases. So after all this is told, they take some time to absorb the information. They will come back to you asking questions whether it is safe or not. Once they are psychologically prepared, that is the time to take these patients up for transplant. The socioeconomic issues with the cost involved has to be conveyed to them. Our center in Borivali ensures that the patients get the transplant at zero cost because of many NGOs supporting the center. There are a lot of schemes available in our country now which are supporting transplants for thalassemia, because we are looking forward to care, cure, and prevention of thalassemia in a big way. And we are hoping the next decade is going to be more and more in favor of the graph of thalassemia births also coming down, and more thalassemia, those living with thalassemia being cured by transplants, in future by gene therapy. And with the newer drugs that Dr. Amit will be talking about, Amit Jain, we can give the remaining population a better quality of life. So I think the socioeconomic issue is in a significant way being taken care of. So you can refer patients who actually cannot afford a transplant to various centers where the schemes are available for transplant. And I think that's a big message I want to give here to all the pediatricians, that no patient or no one living with thalassemia needs to worry about the cost involved, because there are many schemes available in the country now. It needs a psychological preparedness and a fitness where pediatricians play an important role. So these are the standard pre-transplant evaluation of the recipient that we do as a transplant team. I'm not going to go into the detail because these are pre-procedure checks. Obviously, a baseline chimerism is done. This is the evaluation of the donor, and the only thing that I want to highlight here is the donor, if it's from the family, even if he's a thalassemia trait, heterozygous, a carrier, he can still be a stem cell donor. That needs to be understood. A lot of families will have questions about risk to the donor. So as a pediatrician, I think you need to be aware of it yourself also, and tell the family that the risk to the donor is only of the anesthesia if the marrow is going to be harvested. If it's going to be peripheral blood, it is usually as like a apheresis machine. So it's going to be a risk-free procedure if completely monitored, and it is completely monitored. So any hemodynamic instability or any electrolyte issues during the procedure are all taken care of, and it is a safe procedure even for the donor. This is the only transplant where we have siblings as donor who are very young. So we have to assure the family that, that it's going to be risk-free for the child to a major extent, and in a controlled setting, the donor, who's another child of the family, is going to be taken care of fully, and can actually resume routine activities the very next day. And before the procedure also, he just needs to take injections for stem cell mobilization. He undergoes a fitness test, eligibility check, and only then they are taken up for as donors for their family members who are suffering from thalassemia. So this assurance has to come from the transplant team, from the referring pediatrician, because they trust you as the pediatrician to, give them final green signal that everything is going to be okay for the donor also. And their concern is very genuine as parents for the other child. So I think pediatricians can have, conversations regarding this also with the family. So this is how we do bone marrow harvest. That's Dr. Manglani, Dr. Puneet Jain, who was with us in the beginning. We were doing the harvest. It is done from both sides, from the iliac crest, and this is done under anesthesia, general anesthesia, in prone position. Again, in a very controlled setting, ensuring that there is no risk to the donor in terms of volumes that are taken. This is how peripheral blood stem cell harvest is done on an apheresis machine, again in controlled settings, ensuring the safety of the donor totally. So after the harvest is done and the patient has been given conditioning drugs, the stem cells are infused, and the patient is kept in an isolated setting along with one attendant in the BMT unit with monitors, so that we can have minimum entry into the room but still continue to monitor the patient 24/7. All this, if it is known to pediatricians, it is good in counseling. All of you are welcome to visit our center whenever you come to Mumbai. And if you would like to see the center and the transplant unit, we allow people to come and visit the center, understand how things are happening so that you can counsel your patients. There is a phase of around, as I told you, 14 to 21 days where engraftment, there is going to be a total aplasia with conditioning drug followed by engraftment. That means there's going to be a recovery of the marrow. So this also needs to be told to the family that it's going to take about 3 weeks after the infusion of stem cells that you would be considered to be, going home or discharged and living in the vicinity of the center. So these are certain criteria on CBC that we follow before the patient is considered for discharge from the hospital, but not from our follow-ups. The immediate issues are something which are dealt by the transplant team. The pediatricians are not directly involved in this, but it's good to know what are the challenges. So we give irradiated blood products. We ensure that the patient, if he's not taking orally, we are giving parenteral nutrition to the patient. We ensure that pain is not an issue and pain management is kept very high on the list for management. Acute GVHD prophylaxis is given in the form of drugs like cyclosporin and methotrexate. There is a risk of a condition called as sinusoidal obstruction syndrome, all taken care of by the transplant team. Immediate infection risks that are there are taken care of by antiviral, antifungal drugs. And there is always a risk of engraftment failure, but if things are tuned properly, things are monitored correctly, the success rate, as discussed in the beginning, is high. 85% of them will go home successfully and engraft. Some of them may have peri-engraftment issues like infections, their immune reconstitution after the cells come back. You need cells to get back your immunity also, which takes about 100 days or so to get back a good immune system back functioning normally and giving you adequate protection against various bugs. So we monitor them in the transplant follow-up, and that is the reason we tell the family to stay in the close vicinity. They are followed up almost twice or thrice a week in the initial phases and weekly thereafter if things are going well. GVHD, which is a disease where T cells in the donor graft go on the offensive and attack. This could be a cause for morbidity and mortality. So you have to be taking care of it, monitoring things properly, ensuring the levels are correct of these medications which prevent GVH, and the patient therefore needs to follow up. So you need to, as pediatrician, you can counsel them to be absolutely compliant with what the transplant team is going to be telling them. They will be in touch with you during the transplant. Most of the parents are in touch with their primary pediatrician every day on daily basis. So it's nice to connect. We also ensure that we are connected with the referring pediatrician so that they can, counsel the family during tough times, during the transplant period, and later during follow-ups to ensure that they are compliant with their GVHD prophylaxis medications, because that is important to keep the graft in place till we say that there is no need for GVH prophylaxis anymore. So beyond 100 days, we monitor them for any signs of chronic GVHD. We ensure immune recovery has happened. We hate to find any graft failures, but we do ensure that if there is mixed chimerism, we titrate various things to ensure that the graft remains in situ. Patients may call you up, the family may call you up and say that doctors are talking of something like mixed chimerism. So mixed chimerism can happen, but if it leads to a transfusion-free state, it is acceptable. We don't have to have 100% chimerism to keep them transfusion-free. So 100% donor chimerism is ideal. A mixed chimerism, if it is going to keep the patient transfusion-free, is acceptable and they are closely monitored. The pediatrician would be informed when the patient goes back that there is mixed chimerism and this patient needs to be monitored continuous, on long-term basis. If they develop chronic GVH, which we try as much as possible to take care of it and ensure that they don't land up with chronic GVH, because chronic GVH itself becomes a form of a long-term disease. So you are dealing with a patient who had thalassemia, transfusion dependent. You don't want to give him another chronic disease. So it's very important to titrate all the medications closer to transplant so that they don't land up with something like chronic GVH. But if they have it, there are medications to take care of it. And most of our patients have very mild chronic GVH. Those who have around 5 to 10%, they have mild chronic GVH. So overall, the quality of life is definitely better as compared to transfusion dependency and the complications that happen. This is a chart which was prepared by the Indian Society of, now it's called as ISBMT. We prepared it in 2016-17 as a vaccination chart for post-transplant patients. And now this chart is handed over to the patient. We ensure that they get killed vaccine within a year of transplant. So generally, they are still on follow-up with us while the killed vaccines are given. Once they are off immunosuppression, then around 2 years, we give them the live vaccine. So this chart is available online also. We give it to the patient and the family so that they can take vaccines. So you have to remember that all the patients who are transplanted, they need to redo their vaccination. They have to undergo vaccination all over again, just like newborns. And it is important because we don't want to lose them to vaccine preventable diseases after winning the battle of curing them from thalassemia by allogenic transplant. So this is an important aspect of post-transplant care, totally falls into the basket of pediatrician. We as transplant team ensure it is done by remaining in touch with the family and the pediatricians. And now we are trying to look for support for these live vaccines also if they are not available through routine vaccination programs. So we ensure that these kids get all the vaccines that are available for vaccine preventable diseases. Pediatricians can also play a role in vaccine preventable in the long-term complications that can occur. So they need to be monitored for secondary malignancies, sexual dysfunction that can happen, endocrine. So less the iron overload to begin with, lesser the complications. And earlier you pick them up, you can manage them better. Secondary malignancies can happen because of conditioning drugs, but the incidence is less. Overall, HSCT versus medical management, as I told you, there is a comparison available, and quality of life definitely with HSCT and the cost involved is going to be better. This is what quality of life means, and it is definitely the assessments are in progress, and there are some studies that have come which have shown that quality of life is better post-transplant. A role of pediatricians, just to summarize in the end, timely referral, optimal management prior to transplant, target a good performance status before so that the child is well in good nutritional state, counsel and create support group for the families of these patients who are living with thalassemia. Be a part of the journey first 100 days through virtual connect with the families and with us. Shared care beyond 100 days, we encourage because we also need someone to take over the care that needs to be provided to these kids in the long run. Vaccination protocols I've already discussed. Late effects monitoring can be done jointly because we call all our patients once a year definitely for late effects monitoring. I request everyone to create awareness. Pediatrician, medico, non-medico, everyone should create awareness about encouraging people to register in the stem cell donor registry so that we don't rely on registries outside. We have our own strong Indian registry where we find donors within the country. So alone we are smart, together we can be brilliant. We have always worked as a team. And this is the team that was there for the first transplant that we did in Borivali in 2018. Prior to this, we have done in Sion Hospital in 2016 onwards, where we had a different team, but Dr. Manglani was the lead there too. So those were the days when we did transplant from 2015. We have come 10 years down the line. We have finished in our center, we have finished 410 transplant, out of which 58 have been for thalassemia. In Sion, they have finished nearly more than 100 transplants. So public sector hospitals are now offering transplants, as I told you, and there are a lot of schemes available for those living with thalassemia to undergo transplants. So to my appeal to all pediatricians is stay informed, join hands transplant is not going to be, only the transplant team's responsibility. It's going to be shared responsibility. All of you have an important role. We can all learn and discover together. We can create awareness together. We all have a role to play. And I think the theme this year is excellent, together for thalassemia. So here are we are here together today talking about thalassemia, trying to create awareness about pre and post transplant care with pediatricians. So thank you for the opportunity to discuss this with you all, and my acknowledgements to all those who are here in the picture, my team, Director Dr. Manglani, the patients and their families who trust us to undergo the transplant. There have been teachers and colleagues who have been guiding us, the team at the center, pediatricians and doctors who are referring patients, trusting us, and MCGM and the NGOs who are funding, and various other schemes in the country which are supporting transplants for thalassemia. And thank you so much. On behalf of my team, I would like to thank all of you who gave us the opportunity to share some, content related to thalassemia transplant. Thank you so much.
Thank you, ma'am.
Thank you, madam.
It was an excellent session, and we have been greatly enlightened by your experience and knowledge in this particular field. And I hope you have given the clear insight what is the role of pediatrician. It has become easy for all the people who are today's attendee, so that we in the future will really can help you or your center in managing the patients pre and post. Thank you. Or Amit.
Absolutely, absolutely a brilliant session by madam, as always, I would say, and clearing most of our doubts. If there are any more, you can please put them in the chat box, and I'll be asking some questions from my side also. But really, madam, it was great to know, see the journey which has happened through, and we are seeing the patients who have been transplanted coming back to us, following up with us, and such a pleasure to see them, transfusion free and doing so well. So thank you, madam, once again for the excellent session. And now, coming to the next part, there are some children who might not be able to get the transplant done for lack of a donor, maybe. So in that case, what are the newer drug modalities that are available? So to speak on that, we have our next speaker, Dr. Amit Jain. Can I have a slide, please? So Dr. Amit Jain also is a pediatric hematologist and oncologist. He's done his PT from Sion Hospital, and then he was there in the center, CTC center as well. So he has done his fellowship from the center, the CTC center itself, and currently he's working as a hemat-oncologist and BMT physician in Sanak Cancer Institute in Mumbai. And over to you, Amit, for telling us about the next, the newer drug therapies which are available for treatment of thalassemia.
Yeah, so thank you, sir. Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. Are my slides visible?
Yes, sir. Kindly make it full screen.
Yes, yeah. You can see.
Okay. So I'll be covering the recent advances in thalassemia. I'll keep it very brief and simple. So, yeah, sorry. So it is important to acknowledge the remarkable progress made in the thalassemia care. Over the last few decades, we have witnessed a dramatic improvement in patient survival. This is because of the recent advances, recent drugs which are available for treatment of thalassemia. So the same survival benefit is seen in Indian scenarios also, this is the article published from the South India, which showed that patients who are taking treatment before 2000, after 2000, there is a significant difference in So there is a significant difference in survival in these patients. So there are many drugs which are available in treatment of these patients. So we'll break it down into 4 parts. Those drugs who are targeting ineffective erythropoiesis, like ruxolitinib, luspatercept, PK activators, those drugs who helps in reducing ion chelations like mini-hepcidin, hepcidin analog, PMPRS inhibitor. These drugs are under trial. We will not be covering these drugs. And the curative options like hematopoietic stem cell transplant, which has been already covered by Dr. Ratna Sharma ma'am. I'll cover briefly on gene therapy and drugs which helps in HbF induction. So these are the current status of the drugs which are available for thalassemia, out of which only 3 drugs are FDA approved. One is luspatercept, which is recently approved for thalassemia, and other 2 are the gene therapies. So we'll cover all these in brief. So first we'll go to erythroid maturation agent, and the drug which is now making interest is luspatercept. So luspatercept is a recombinant fusion protein that promotes maturation of RBCs, thereby reducing ineffective erythropoiesis. So it is labeled as Reblozyl, approved in 2019. It is approved for patients with transfusion-dependent thalassemia, which is more than 18 years of age. The trials are going on in pediatric patients, and we'll soon get it approved for a pediatric patient also. So the route is subcutaneous, and the dose is 1 mg per kg, can escalate to 1.25 mg per kg based on the tolerance. So this is approval is based on the BELIEVE trial, which was a randomized phase 3 control trial 2:1, in which 336 patients were included. The primary endpoint was more than 33% reduction in transfusion burden. So in the luspatercept arm, they have seen that 21.4% patients achieved the primary endpoint, means the reduction in transfusion requirement was more than 33% in 21.4%, as opposed to 4.5%, which is in placebo arm, which is clinically very significant. Not much adverse event noted in these patients. The commonest ones are bone pain, hypertension, and thrombotic events. None of the patients required discontinuation of the therapy. So this was in transfusion-dependent thalassemia. There was one more trial in BEYOND, which was in non-transfusion dependent thalassemia, phase 2 randomized control trial, in which primary endpoint was more than 1 gram hemoglobin rise. And results are that around 77% achieved their primary endpoint. And the drug was very well tolerated with limited side effects. So this is one drug which is approved in pediatric patients for transfusion and non-transfusion dependent thalassemia. There is one more drug which is under trial, sotatercept, with similar mechanism of action, and will probably get approval in these patients. Another drug which is in process of approval is mitapivat, which is pyruvate kinase activator. It has already been FDA approved for pyruvate kinase deficiency. So it is an oral first-in-class oral activator of erythrocyte pyruvate kinase. Works by activating pyruvate kinase enzymes, thereby increasing in ATP production, which led to reduced ineffective erythropoiesis. So this is based on the phase 2 open label trial of mitapivat in 20 patients in non-transfusion dependent thalassemia. They received escalated doses of mitapivat, and they found that there are 80% patients in which hemoglobin rise was more than 1 gram percent in NTDT arm, beta thalassemia arm, while in alpha thalassemia, all the patients achieved the primary endpoint with limited side effects, and none of them required discontinuation of drug. Ruxolitinib, which is a JAK2 inhibitor, which makes noise when it was tried for thalassemia, but what they noticed is that this ruxolitinib does not help in reduction of transfusion, but during the trial they noticed that the patient who have splenomegaly or hypersplenism, it helps in reducing the spleen size. So the current indication in which we can use ruxolitinib is patients with hypersplenism or those with splenomegaly before transplant. If they are planning for transplant, we can use this drug for reducing the spleen size. Moving on to fetal hemoglobin inducers, HbF inducers. So actually the next two drugs are not recent advance. These are available since many years, but most of the patients and most of the pediatrician encounter these drugs or patient are on these drugs. So better to cover these drugs also. Hydroxyurea, which is used mainly in NTDT patients, beta thalassemia intermedia patients. So in these patients to reduce anemia and transfusion requirement, it increases HbF production by multiple mechanisms and reduces the ineffective erythropoiesis. So more, around 30 to 50% patients show significant rise in hemoglobin and with rise in HbF, reduces transfusion frequencies and improving in symptoms. So the starting dose is 10 mg per kg per day. We can go up to 20 to 25 mg per kg per day based on the tolerance of the patient. And we need to monitor CBC because it is a myelosuppressive drug, along with that liver and renal functions. So these are meta-analysis performed for hydroxyurea and thalassemia patients. So most of the meta-analysis was performed in Middle East countries and Southeast Asian countries where the predominant HB thalassemia and non-transfusion dependent thalassemia population is predominant. So the finding showed that the hydroxyurea response in these patients are around from 25% to more than 50% requirement of transfusion requirement reduction. But point to note here is that most of the populations are of the category of non-transfusion dependent thalassemia, and they have also noted that hydroxyurea works better in HBE beta thal population and also those patients who have XMN1 polymorphism. So this was the Cochrane analysis for hydroxyurea and transfusion-dependent beta thalassemia, in which the author concluded that there is no high-quality evidence to support hydroxyurea in these patients, and even the recent guidelines TIF 2021 does not recommend hydroxyurea as first-line therapy in TDT patients, but they have now recommended in NTDT patients with severe symptoms. Moving on to thalidomide. Thalidomide also works as HbF inducer. So this was the published report from India in which the two doses of thalidomide was compared 1 and 2 mg per kg per day in 188 patients in a randomized manner for 6 months. The around 55% patients got response with that. And they also note that the patient who are on low dose have better response as compared to patient who are on high dose. Response was graded according to the grading, like if patient transfusion requirement is more than transfusion requirement reduction is more than 50%, then they are good responders. If requirement is between 25 to 50, then moderate responders, and less than 25 is 40. So they noted that around 20% of the patients may become good responders with limited adverse event. Only few patients develop grade 2 or grade 3 toxicity. So currently it is not approved for patients with thalassemia, but same like hydroxyurea, patients with HB beta thal show very good response in patient with HB beta thal. Those who are non-transfusion dependent thalassemias have better response rate with thalidomide. So now moving on to gene therapy, those patients who are not candidate for hematopoietic stem cell transplant, who does not have donor for hematopoietic stem cell transplant, or who are ineligible for hematopoietic stem cell transplant, they can consider gene therapy. However, it is not available in India. So what is being done in gene therapy is patients' hematopoietic stem cells are harvested either from bone marrow or by mobilization from apheresis. These hematopoietic stem cells are modified in lab using viral vectors, either by introducing gene or by or by like modifications in gene by adding, deletion, or altering the functions by gene editing. So once they are transducted or gene editing is done, these cells are expanded in huge numbers in billions and then reinfused in the patients after myeloablative conditioning. So with this, there are two trials, one of gene therapy in form of gene addition and one is by gene editing. So this is the first trial, the gene therapy name is Zynteglo. They included 23 patients, out of which 22 were evaluable, and they found that after a median follow-up of around 30 months, they noted that 20 patients are transfusion independent with maintaining adequate hemoglobin. So this was the landmark trial in thalassemia. However, they included only non-beta 0 thalassemia. So it got FDA approval in 2022 for beta thalassemia patients requiring transfusion, regular transfusions. And the route was single IV infusions post myeloablative conditioning. The challenge here is the cost. Cost is around 2.8 million for a gene therapy, which is which is actually a limiting factor for our population of patients. Moving on to the gene editing, which is CRISPR-based, CRISPR-Cas9 based gene editing, in which they suppress the BCL11 gene so that the HbF production is increased and thereby hemoglobin become normal. So this trial included beta 0 patients, which are actually the severe variety of patients. And out of 30 evaluable patients, they noted that 29 patients become transfusion independent with maintaining adequate HbF levels, and because of this, it was FDA and EMA approved in 2023. So the difference here is Zynteglo or gene addition therapy. The chances are better with CRISPR-Cas9 because of the gene editing, because of less mutagenesis because the viral vector was not used in CRISPR-Cas9, and better results even in beta 0 thalassemia. Moving to the last slide of my presentation. So most of you are aware that there are 3 ion chelators available in market: Deferasirox, Deferiprone, and Desferoxamine. So the recent advance, the last, I think, Deferasirox film coated tablets are available, which most of you are aware. The recent, most of us have used dual chelating agent in very high ion overload patient. This is the recent publication in Lancet in which they have used triple ion chelator in very highly ion overloaded patient in a randomized control setting, in which they have included 23 patients. And noted that triple therapy has showed significant reduction in ferritin and also in cardiac T2 star MRI, in which T2 star MRI improved in 67% of the patient as opposed to those who are 20% those who are on dual therapy. So, but there is no significant difference in liver ion overload. Along with that, Deferiprone, Calfer, caused reversible arthralgia in some patients, in which required discontinuation of the therapy. So those patients who are planning for transplant with significant ion overload, we can try triple therapy for these patients for achieving better cardiac ion overload reduction. Thank you.
Yeah. Thank you, Dr. Amit, again for a brief and crisp presentation. I think what we know about thalassemia, the drugs that are used are hardly a few of them. That is hydroxyurea and thalidomide, maybe. We have heard of them. Personally, as a pediatrician, general pediatrician, don't use many of them. But there are so many newer drugs which are there in the market, and it's good to know about them. Even though I understand that most of them are still not approved in pediatric population, except for some of them, but they are again for non-transfusion dependent thalassemia rather than the common ones. So again, an
Yes,
excellent
most.
presentation, Mark and Chris. Thank you so much. Yeah, this is
So most of the drugs which are available for management of thalassemia works better in non-transfusion dependent patients. So for transfusion dependent patient, option left is either HSCT, curative option left is either HSCT or gene therapy. Gene therapy is actually far from our hand. So if we can
So I think
prevent.
with the way advances are happening and the way things are moving in our country, gene therapy, if indigenously made in our own country, which is going to be the future, we obviously cannot afford what is available in the West. But from whatever meetings are being held towards gene therapy in India, I think it's not too far. So the message here to pediatrician is whether it is gene therapy or it is transplant, the child has to be in a good condition to undergo any of these. So while we are giving them hope for gene therapy, we have to ensure that their comprehensive treatment now is optimum as per the guidelines. There are guidelines available through Indian Academy of Pediatrics PHO chapter for thalassemia. I would request all the pediatricians to refer to those guidelines to give them optimum care so that whenever they undergo transplant or gene therapy in future, we find most of these patients eligible for it. It will be too disheartening to know that they are not eligible because they were not managed well in the early phase of their life. I hope that message is clear, and that responsibility lies with all of us, the hematologists and the pediatricians. So that's a appeal that everyone should take optimum care of these patients, refer to the guidelines and use the guidelines. They are available on the website of PHO also.
absolutely, and I think that is a very clear message that we have given, that the pre-transition or pre-gene therapy management should be absolutely correct so that the children are there. We do have some questions in the chat box. Dr. Ramakant wanted to know how young a child we can transplant and how old a person we can transplant, and also how young the donor can be for a transplant.
So to answer that question, it depends from center to center, but for all practical purposes, we as a center are more comfortable managing 2 year and above for transplant. For practical reasons, that the communication between the child to understand the issues that the child is undergoing in the transplant unit, the medications that are given, the doses that have to be given, everything practically is more practically possible to do in a 2 year and above kid. So that is what we have kept as the age criteria, and we require that much time after diagnosis to counsel the family, to raise the funds, everything. So it takes time. So we haven't transplanted a child living with thalassemia below 2 years of age, but for other indications we are transplanting even less than 1 year of age, like inborn errors of immunity or neuroblastomas. So transplants can be done in younger kids. Thalassemia is an elective transplant, so we generally opt for 2 years and above. There are centers who have done it even earlier. Regarding the upper age limit, there is no upper age limit if the patient or the person living with thalassemia has been managed well. But currently in our country, those who are more than 15, 20, because of the prior non-availability or non-compliance to chelating drugs, they are not in a condition to undergo transplant. So that becomes a reason. Those who are older are considered to be high risk because they have got more transfusions and they are likely to have more iron overload. If iron overload is taken care of optimally, then the risk comes down. In our center, we have not been transplanting more than 12 years of age. We prefer less than 10 or even 8. So if the child is going to turn 6, 7 and he's in the wait list, we take them up for transplant for sure. Currently, we are not getting referrals, older ones who are well managed, to take a jump and do transplant. Anyway, our center is a pediatric transplant center, so we don't transplant anyone above 18. There are centers in India who have done few transplants in older, well managed patients who were chelated very well from the beginning, though they were born before the dispersible ion chelators were available, by giving subcutaneous Desferal. So that is the message, that there will be no upper limit if they are managed well. It will depend from center to center what they are comfortable with. The last question was for the donor, how young the donor should be. So we can do peripheral blood stem cell harvest even in a 6-month older or a 1-year older, if everything is in a control setting and it is taken, every safety of the donor is taken care of. But we prefer that if the age of the recipient is not a limiting factor, that means the recipient can wait for 2 or 3 years and the donor is a infant, then we try and wait till the donor also becomes 2 years of age, for practical reasons of handling them on the apheresis machine. Because otherwise they need to be sedated. There are centers who give they give sedation, they do under GA. So we don't want to get into that when it comes to donor, because we want to keep the risk to the donor zero or very minimum.
So, madam, you talked about the stem cell registries, and I think it's a very important point that everyone should know how to register for them. So, can you tell us that which are the registries available in India and how to, motivate people
Yes.
to go there?
So the registry is available in India. Anyone can go online. There is Datri registry, which is more popular in India. You have another MDRI registry. Amit can name a couple of you. The DKMS also has Indian portal. So these registries are available online. Those who are interested can mail to the registry. They send them a kit. The kit is self-collection of buccal swab, and the donors who want to be the voluntary donors who want to register can send the buccal swab back to them by courier. There are camps held by registries. You can go to their office also and deposit the samples. So it is doable. And if any one of you is interested in arranging a camp for collecting more donors to register in the registry, you can just mail them and they organize camps also in corporate setup, in colleges, wherever you tell them. So they are more than happy to have these camps for more registrations.
Yeah, I think that also the awareness should be made that it's not going to be a risk procedure at all for the donors, so that more and more people are motivated.
So
to
when they
do
do the camps, now they actually do a talk before that to ensure that those who are registering are actually willing for donation. It's not that they are just coming as a herd mentality or because they have children with thalassemia, but they are going to be available when the call comes. Okay, you have matched, they should not back out, because the back out rate in India is still pretty high. So they register, but they don't actually agree when they get a call for registering, for donating stem cells.
Is there any cost factor involved in that during collection or anything?
So earlier, most of the registries were actually enrolling free of cost. But now, after counseling and after confirming that they want to be a donor and they don't want backouts, if anything is available free, you just go and register. You don't want to. So they have involved a very minimal cost. But I think those who are enthusiastic about donating don't mind. And because the testing, they have to do the HLA typing, right? So but the cost is very minimal, and that also sometimes we have debates with them, make it zero, or don't come back with the idea of the cost. But they have their own reasons, and I think now we are getting people to donate in India willingly. The backout rates will gradually go down with more and more awareness and education.
And then there's a very popular thing, rather, I would say, is that umbilical stem cell collection, cord cell collection. Is that got any role to play in this donor HSCT transplantation?
Yeah, so earlier cord stem cell transplants were being done, and especially Apollo Chennai Group was doing it. But there is a challenge with it. One thing is that the dose of the stem cells, sometimes you don't get adequate stem cell dose. So this child who's born, whose umbilical cord stem cells have been stored, is actually available, right? The child is also available within the family. So you can actually do apheresis. And as I told you, age or weight, the weight is not a great limiting factor for apheresis. So you can apherese the child. So you'll get better yield of stem cells by apheresis rather than using his umbilical cord stem cells, which have their own viability issues also. Second, in umbilical cord, the engraftment period is little delayed. So what happens is that the risk of infections during the neutropenic phase of the patient gets prolonged. That the neutropenia phase is prolonged, the risk of infection is prolonged. So transplant-related complications, the chances of infection and morbidity or mortality related to that is high. So all of us have now gone back to believing that stem cell, peripheral blood stem cell harvest from the sibling whose cord blood was saved is a better option than using the cord stem cells. So some of them have used as a top up with marrow harvest in the past, but with good machines available for peripheral blood stem cell harvest and the less the risk of rejection with these stem cells, I think everyone is moving towards that.
Also, one more thing, you mentioned about HLA typing. We can do it from our side before we are referring to the center for transplant. Any specific method of typing that we should mention while doing it, or any things are acceptable? On any specific
So-
lab that we are supposed to send to?
So you can have high resolution typing, which can be done. And now most of the transplant units want high resolution HLA typing report before they go for transplant. And ICMR has now guidelines for transplant units, what type of, for standard of care basically. So for any, so in matched sibling setting, it could be a little different, but MUD definitely. But we as a center go for high resolution typing. Amit, you want to comment on it?
High resolution is actually better if they do not have. No, so high resolution is always better. So if they do not have matching donor, then ultimately the patient high resolution typing is required for unrelated donor search.
So when you have a matched family donor, the sibling is a match. Like in the beginning, we also were not doing high resolution when we started off 10 years ago. Now the cost of all these investigation has also come down. So high resolution is available as a routine in labs which are doing HLA typing. The cost has come down significantly. And you don't want to repeat the HLA typing again, from low resolution to high resolution just before the transplant. So it's best to ask for high resolution.
Okay. Amit, for you, like when a patient is waiting for transplant for this, any specific method by which your PRBC should be transferred, like they should be irradiated, non-irradiated? What all things should be taken care?
Yeah, so ideally patient should receive irradiated leukodepleted blood. Leukodepleted always, but irradiated at least 6 months prior to the transplant. They should maintain adequate hemoglobin around 10 gram%. If they have hypersplenism or extramedullary hematopoiesis, hypertransfusion should be considered with adequate chelation. These things should be considered when the child is planning for transplant.
Okay. Coming to the drugs, Dr. Vaishali wanted to know what is the dose of folic acid? Is it really required? And if yes, what is the dose in transfusion-dependent thalassemia and NTD?
Shall I
Folic
take
acid.
it?
Yeah, you can answer it.
Yeah. So in transfusion-dependent thalassemia, actually folic acid is not required. In non-transfusion-dependent thalassemia, because of extramedullary hematopoiesis, folic acid is needed to help the marrow. So dose is 1 mg per day is enough. But because the tablet comes in 5 mg form and it is water soluble, we can give 5 mg per day also.
So 5 milligram per day will not make a difference as such. You talked about hydroxyurea as a HbF inducer. I've seen certain patients being started on hydroxyurea when they are initially like 6 months, 7-month-old children, who are, or 9-month-old children rather, who are started on hydroxyurea when they are diagnosed with thalassemia. Is it the way to go ahead, and see whether they become non-transfusion dependent for some time, and once they require transfusion, you start transfusion later? Is it the way to go ahead, or rather, I would say, how do you start transfusion regimens in children who are diagnosed with thalassemia, homozygous?
So to label patient as transfusion dependent thalassemia, their hemoglobin should drop less than 7 twice to at least 2 weeks apart after ruling out all other possibilities like infection. suppose here if patient is maintaining hemoglobin of hovering around 7 to 8 after even 4 to 6 weeks of last transfusion, then in that case we can consider hydroxyurea. Hydroxyurea in these patients, and if they respond, we can label them as non-transfusion dependent thalassemia. But actually, those who diagnosed before 6 months, unlikely they'll respond to hydroxyurea unless they have some molecular factors like beta plus along with XMN1 polymorphism.
So what we do, what Amit is trying to say is excellently put it. What we are trying to say is that when patients are referred to us, if they have received a single transfusion and they come to us, we look at the cutoff at which transfusion was given. We look at the need for second transfusion when the hemoglobin drops below 7. We see the interval between these two transfusions and then decide whether this patient is likely to become a transfusion. So now the terminology, as you all would be already knowing, we don't call them major or intermediate, we call them transfusion dependent or non-transfusion dependent. So we try to give them an opportunity to get less transfusion if they are heading towards a non-transfusion dependent type of phenotype. And that could be a inherent genetic, the genetics is such that the child is going to be an NTDT because of the variant that he has or a coexisting factor that he may be having in his genetic makeup that makes him non-transfusion dependent. That means his transfusion requirement is not monthly like a transfusion dependent. Or we see whether he will be helped by medications like hydroxyurea to make him a less transfusion requiring patient so that his iron overload is less. And the guidelines clearly mention that when you're monitoring these patients who don't require transfusions as regularly as a transfusion dependent patient, they need to be growing well. They need to be having a normal pulmonary pressures. They need to be having their growth spurt correctly at the time pubertal spurt. So all these things have to be taken care of. They should not have any morbidities associated with not getting transfusions regularly. Only then you continue the management as NTDT. It could be with hydroxyurea or it could be the basic phenotype of that patient. So they need to be monitored. And they do have iron overload. So they need to be monitored for iron overload even if they don't get blood as regularly because of absorption from the intestine. So hydroxyurea, what you're saying, Dr. Amit Saxena, hydroxyurea can be tried early also if you see this pattern in them that they are heading towards NTDT pattern.
And what is the that you can start hydroxyurea?
What is the youngest age?
Hello.
You're asking what is the youngest age?
Youngest age to start hydroxyurea?
So hydroxyurea was predominantly used in sickles and sickle patients, and the trials which were done in sickle cell anemia have shown safety of this drug as early as 9 months of age in sickle cell disease patient. So we extrapolate from that and we give to our patients, but we at our center generally avoid till 1 year of age, but you can give safely without any damage to the organs.
Okay. I think one last question was there from Dr. Naresh. What is the cancer is very high after gene therapy is what we wanted to know, and also where are we in the Indian gene therapy trial? What phase are we? That's what we wanted to know.
Amit, you can also answer this question because you presented about gene therapy.
So yes, there were some case reports of AML in sickle patients. But finally, the AML, out 2 patients developed AML in which one patient had clones of AML in vectors. So probably we are not sure whether the vector is causing AML or it is because of the inherent cause in the patient. But yes, there are 7-year data is already there for thalassemia, and in thalassemia cohort, none of the patient developed malignancy. And coming to second question, so currently CMC Vellore group is doing clinical trials on gene therapy of in hemophilia patients, and they have recently published outcomes of 5 patients in which all of them are factor. All of them didn't require factor, and none of them have any bleeding episode. As far as thalassemia is concerned, probably we'll have to wait for 1 or 2 years to get trials in India.
So the lentivirus that is used now is not supposed to have that much risk of oncogenesis. The retroviral that was being used earlier was known to have a risk of insertional mutagenesis. So that was the risk with retrovirus. Lentivirus has been proven to have less risk, but yes, there is some amount of some reports, as Amit mentioned, but we are looking at something much safe, in the future with lentivirus. So it depends on the vector that is being used. Yeah.
One last question that I want to ask is, after how long of a transplantation we say that, okay, fine, the child is absolutely done and we need not follow him up?
So we follow them up very closely till they are on immunosuppression. Unlike organ transplants, the hematopoietic stem cell transplant patients don't require lifelong immunosuppression. So it's about 1 year to 1.5 years in thalassemia if things are going fine. The graft is in place. The patient has full donor chimerism. He's not requiring transfusions. He has no morbidities in terms of chronic GVHD. The things are going to be smooth in future. The risk of malignancy, secondary malignancy, because of the drugs which were used in transplant for conditioning his marrow, that risk is it's there, it's less. And there are patients who have got secondary malignancies post-transplant, but the risk is very less. So the monitoring never stops, Dr. Amit. The monitoring will continue, but with a better quality of life. Once a year in the long run, pediatricians will be there, physicians will be there to understand what the follow-up is like. We all are encouraging anyway health checkups for everyone in thalassemias. Patients living with thalassemia anyway have to undergo their checkups. So those who are transplanted will also undergo routine checkups. But the frequency is going to be less and acceptable to them, obviously. If their iron overload is not bad to begin with, they will not require, they will not have toxicity related to iron overload in future. I will just mention here that their iron overload can be taken care of post-transplant. Some of them require post-transplant iron chelator for some time or phlebotomies to bring down the iron overload. We don't discharge from our side till the iron overload is taken care of post-transplant.
Okay. I think that's all the questions. If any more in the audience has any questions, or have any questions.
I'll also make one comment, encourage your patients to continue to follow up with the transplant team, because if we have a good follow-up plan in our country, we can give long-term data of our
Yes,
cohort.
that's it.
And this is what will come from your end. You have to tell them to report. So the latest meeting that happened of the Indian Society of BMT, ISBMT, they said 4,000 plus. If you want the exact number, I can give you 4,000 plus transplants of thalassemias have been done in our country so far. I'm not sure whether they have follow-up of all the patients, because they mentioned that what we are lacking is follow-ups in our country to tell how they have done. So I think we should encourage follow-ups. We should not say how long they need to follow up. They need to follow up, and we will all ensure that they
Yes,
follow up so that we can pick up the complications of long-term also early in there if they happen.
very
To
true.
be precise, 4,277 patients of thalassemia have undergone transplant in our country from 1983 till 2024 December is what the Indian data is so far. Among the 34,800 transplants that have been done in our country till date from the start, the data that Indian Society of BMT has. And we are looking at bigger numbers because the number who need cure is much more in our country.
Thank you, Ratna Madam, and thank you, Amit Jain,
Great,
for the
wonderful
wonderful
discussion.
presentation and excellent discussion. Thank you.
Excellent. Actually, you answered all the queries, so that Amit has also asked so many questions. So I think there is hardly any need of any question. And Madam very well told, in the long run, we need a follow, not we need a follow-up. We need to do the follow-up of all those transplanted patients, so that we should have a data, and long term only we can later on collect what has happened.
We'll
to them.
get better that way. We'll get better
Yes,
that way.
yes, very true, very true.
Thank you for the
Over to you, sir.
opportunity.
Yes, thank you, ma'am, for accepting our invitation, and today's accepting our invitation of the speaker. Thank you, Amit.
Thank you, sir.
Really,
It was a
it's-
pleasure and
we
privilege.
thought it was a very complicated thing, but you made it so simple. So I think many people are who were the attendees, they got the in-depth knowledge about, and will become the more responsible toward their patients and referring to and coming after post-transplant, managing them.
Thank you so much.
Thank you. Good night, ma'am.
Thanks.
Good night.
Thank you, everyone. Bye bye. Bye, Samruddhi. Bye, Dr.
Thank you,
Doctor.
ma'am. Thank you, sir.
Dr.
Thank you,
Abu.
ma'am.
Thank you.
Ma'am, yeah, I would like to request now Dr. Amog ma'am to kindly deliver the vote
Okay.
of thanks. Yeah.
Just bear for like 2 minutes.
Sure. No, I
The vote
shouldn't
of
have.
thanks. I would first of all like to thank MyApply platform, Dr. Sanjay Pakmude sir and his team for giving us this fantastic academic sessions in every Thursday thrill and continued learning. I would definitely like to thank the esteemed speakers for making thalassemia so simple and taking us throughout the evolution, the management, and what more we can do for them from a pediatrician's point of view. And you've shown us hope, because when we were residents, it was all about just transfusion and managing the complications. But now we're seeing so many BMTs and so many children doing so well. So it's really giving us a ray of hope. I would like to thank Dr. Samruddhi for a beautiful conducting of the whole session, and definitely the moderator, Dr. Amit Saxena, for managing the question answers so beautifully. You covered the whole thing on thalassemia. I would like to thank Pallavi ma'am, who is the digital head at MyIP, for always being, in support of all the programs that we conduct online. And I would like to end with a small message that hope, care, and knowledge are the best medicines. Let's stand united against thalassemia. Thank you, everyone, for a patient hearing, and have a good night.
Thank you.
Thank you.